course from Exam Pro. I'm Dr. Lou Foley. I'm one of the senior Exam Pro faculty, and I'm really glad you're taking this course because I am a firm believer, based on more than 20 years experience working with candidates preparing for this exam, that the best prepared candidates start with a thoughtfully and carefully constructed case list. I also want to start out by mentioning that case list construction is not one size fits all. And in our course, you're going to get advice from multiple different faculty members, seasoned experts who have worked with candidates for a long, long time. And sometimes our answers differ on the same question on how to enter or approach a particular case list construction issue. Now, this should reassure you rather than worry you. And I just want to touch on this because as you are listening to our course and you hear different faculty, there may be a few disagreements or different perspectives on particular issues. And I want you to think about this. First of all, there are many best practices to case list construction, and I think you'll find consistent agreement among our faculty on the best practices. There are some fatal mistakes that you want to avoid, and I think you'll find consistent agreement on our faculty in that regard as well. And then in the end, there's a certain amount of constructing a case list that comes down to style. And that's where the options and the disagreements come in. So I'm going to spend the next hour and a half going over the most important information and tips that I find that many candidates have overlooked or underappreciated while preparing their lists. And I will mention this again, I think later, but I want to mention it right from the outset. Realize that it may not be appropriate for you to use every technique or strategy or suggestion that we present to you. Please, as you construct your case list, write this down. Don't do something because Dr. Foley at Exam Pro told you to do it, okay? Instead, consider each suggestion, each strategy, each technique, each tip, and incorporate it where and if it works for you. And I think you will find that a lot of these things are easy to incorporate and they'll work quite well for you. And let us help you optimize you, okay? And that's really the key. So let's go ahead and get started here. I'm going to make two assumptions from the outset, and I'm just going to state them. The first assumption is that you want to pass this exam. Otherwise, you wouldn't be taking this course. You wouldn't be doing all of this work. And I'm sure that's why you're here. And we want you to pass the exam too. And again, the case list is a fundamental key part to optimizing your chances of passing. The second assumption is that I'm going to assume that you are just starting to think about preparing your list. And for many of you, not exactly certain how to do it. And so I will tell you, I'm a detail type of person. Details do matter. There are a few basics on this slide just to get you started. All of this is on the ABUG website, but as you're starting to construct your case list, remember these key things. Deadlines, they come up quick, time goes fast. So keep 2 times of the case list collection year in mind. First is June 30th. This is, of course, the final day of the case list collection year. We collect from July to the following June. And the second time frame I want you to keep in mind is the first week of August. Whenever you are doing your oral board exam, we all have to submit our cases sometime in that first week of August. Make sure you know that deadline. Make sure you're well ahead of it. Don't have to prepare your case list the night before it's due. Please pay close attention to the timeline that you are on. Another basic piece of information that I think is really important that you should familiarize yourself with is the ABUG bulletin for the oral exam. Of course, the oral exam is called the certifying exam. This is on the ABUG website. Usually the bulletin is about 40 plus pages long. It's reworked every single year. It's tedious, but it's full of important details and instructions. And I don't mean you have to memorize every single page or even to spend much time reading it, but I would specifically look at the sections of the bulletin that talk about case list use in the exam and construction of your case list, because you'll see there's some very important details there that will help you. So you're going to be making 3 lists. That's the last thing on this slide. You're going to be making your GYN list, your OB list, and your office list. These lists are essentially mutually exclusive. What I mean is that any given patient should really only appear on one list and on that list only as a single entry. And I'll talk about this a little bit more later in the presentation. All right, moving on. How important is your case list? Well, think about this. Your exam is really 3 separate exams, each 1 hour in length. And the examiner's questions to you during the exam will originate from information on your case list during 30 minutes of each hour. Therefore, if you look at my little graphic at the bottom here, about half of your overall exam is based on the information on your case list. You have structured cases for 30 minutes plus questions from your case list for 30 minutes in each hour, GYN, OB, and office. And so the quality of your case list and the information that is offered on your case list will definitely be a major part of the exam. Now, think about this too. Examiners have a tough job. Usually they're going to administer 3 exams in the morning and 3 exams in the afternoon. So that's your exam plus 5 more. They get access to the information, to your case list, the section that they're examining you on, usually the day before, the night before your exam. And so they've got to review all of these case lists. Is this the impression that you want to leave them with? Frustration, difficulty understanding the points you're trying to get across? I really don't think so. And so again, this is why case list preparation is so important. I prefer to have the examiner have this kind of feeling when they see your list. They're ignoring their dog because they're enjoying looking at your list so much. They're thinking about all these great topics and all the juicy questions that they're going to ask you. Of course, if you've done a good job on your list, you'll be ready for those questions as well. So it should be a no-brainer. Optimal results, passing on this exam, are highly influenced by your case list. Effort spent on case list preparation pays off. So hopefully I've convinced you. Let's continue. And I want to talk for just a second about which patients do you put on your list. So a few key points. GYN, remember, and the reason I'm pointing this out, because this is all in the ABOG bulletin, but these are things that I see people overlook time and again, and they figure it out near the end after they've already done their list, and then they have to go back and make changes or fix things, or they sometimes can't. So again, I want you to start out with the right mental framework. For the GYN list, essentially all hospitalized and short-stay GYN patients have to be on that list. So any patient admitted to the hospital with you as the attending, and any patient operated on at a surgery center with you as the attending has to be on that GYN list. Now, for OB, again, all admitted obstetrical patients, except for the normal obstetrical patients. And you can see the ABOG bulletin for the definition of what that is, but they do have a definition. It's basically a term, uncomplicated pregnancy and delivery. And when you read the definitions, you'll be able to identify the cases that fall into that. And in those cases, you don't need to list them on the case list, but everybody else gets listed. For patients that you admit but don't deliver, like a patient with preterm labor, you do not list the delivery information or the infant information, but you do list the patient and her information regarding your antepartum admitted treatment, hospital treatment. Now, I want to point something out about these 2 lists. Sometimes people get confused. They'll read about when you use like senior residency cases. If you're somebody who doesn't do OB or doesn't do GYN, usually it's a subspecialist, then you won't have a list to submit, so you'll use senior residency cases. When you do a senior residency case list, you only submit 20 cases. When you are practicing OB or GYN, you submit all of your cases. It's a very, very important point. Don't confuse this. All of your hospitalized GYN and all of your hospitalized OB patients during the case collection year must be listed. Then we get to the office list. The office list is a little bit different. You're going to have exactly 40 patients, no more, no less. They want 40 patients. And when you read the bulletin, you'll see that there are certain categories and you can only put 2 in each category. Take a look at that information. But basically in the office section, you can list patients, of course, that you see in the office. You can also list patients that you saw in the emergency room, provided they didn't get admitted to your GYN list. You can see patients you did L&D triage visits for, provided they didn't get admitted to your OB list. And you can see virtual office visits as long as the patients are not on your OB or GYN lists and you encounter them in the ambulatory setting, you can include them. You can also include patients who have procedures that are performed in the office. So let me mention something here. If your office is basically also got a surgery center set up, but it's in your office, then there are going to be procedures that are a little bit more advanced that you can put on your office list. If the surgery center is across the street, not in your office, then of course those patients go on your GYN list. And notice I'm saying in the office list that you can list these patients. Because it's only 40 patients and because you get to choose which patients, you don't have to list anybody. And I'm going to touch on that at the end of this presentation. So we'll come back to that very important piece of information. All right, so what I'm going to do now is, again, I'm going to focus on some things that I noticed that candidates overlook that are really important for optimizing the list. And our other faculty are going to focus on things that they believe are important. And so there'll be some overlap, but there'll be a lot of things that potentially will be different between our presentations. This slide talks about the first things I want you to be thinking about as you construct your list. Make it easy to read and follow. Make a good first impression on your examiner. I'm a big believer that first impressions can have a lasting impact. And if it's a good first impression, they often will set you up for the presumption that you're going to pass. Bad first impressions also have lasting impacts. They're hard to overcome. I do not want the examiner to formulate a first impression of you based upon a poorly constructed case list, despite the fact that you're an excellent physician. So make it easy to read and follow. Do not narrate on paper. Lay your case list out as a summary, and I'm going to show you some examples here. Use approved and appropriate abbreviations. Let's go through these 3 points. So first of all, when we talk about not narrating and making it easy to read and follow, I talk about the less is more principle. This is an oral exam. Do not narrate on your case list. For example, when you talk about in the treatment column and maybe in the office list or in the OB list or in any of the lists where you talk about smoking cessation counseling, you can just list in the treatment column smoking cessation counseling. You don't need to write something like, I counsel the patient to quit smoking, including the risks such as lung cancer, chronic lung disease, preterm labor, heart disease, again, DVT, we could keep going. You don't need to narrate. You just need to mention smoking cessation counseling. In the oral exam, the narration will come when you are answering the question. The question will be something like, tell me about your smoking cessation counseling. Now, this is a simple example, a different example of narration on an actual case list. So this was actually on somebody's case list, not recently, but because I don't want to, expose anybody and it's been de-identified. But this is what they put. You can see in the antepartum complications column, they describe the patient's previous cesarean delivery and arrested descent and pushing previous pregnancy, not even the care that this candidate gave. You can see in the delivery or postpartum complications column, they talk about a fascial disruption with an impressive hematoma. And then in the procedures and treatment column, you have this basically storytelling about what was done to treat the patient's complication. And most of this information is unnecessary, but even the necessary information is hard to decipher because you have to read the whole story. And remember, your examiner doesn't have that much time. You don't want to get them going, oh, like I showed you in that original slide. So let me show you. This is the exact same case. Okay, I'm going to go back for a second so you can see this is the case. This is now the case. And here I've just simplified things. History of CD for arrested descent, declines TOLAC, wound hematoma, fascial disruption, repeat cesarean delivery, and readmission for evacuation of hematoma and repair of fascia. Now you'll notice I put a little line space in the treatment column between repeat cesarean delivery and readmission. I think it's helpful when you have a patient who has multiple encounters to put line spaces into your list. So for instance, on the GYN list, if a patient had a hysterectomy and then was readmitted for a vaginal cuff dehiscence, then I would put a line space between those two encounters, but the patient only gets entered one time on the list. This patient doesn't need to be listed a second time for the readmission. The readmission just needs to be documented with that line space there. And if you have questions about this kind of stuff, again, we're always available to answer questions for folks. But the point is that we've simplified this case by not narrating, and I've also included a few abbreviations. So let's talk about abbreviations. With abbreviations, they make things quicker and easier to read. Okay, they really help with communication. The less wordier and easier it is to read your case list, the easier the examiners can follow what you did and why you did it. However, abbreviations only help if they're understood by the reader. Okay, so you might have abbreviations that you like to use that are non-standard, that are somewhat less commonly used, and this might actually be confusing. So I'm going to point out that ABOG has an approved list of abbreviations in the ABOG bulletin every year. I encourage you to use the abbreviations every chance you can. And let me just go forward here and show you an example. This is an OB case with no abbreviations. And this is a fairly wordy case because of the way it's been entered. I'm going to show you the same case right here. Okay, so let me go back one slide. Again, it's an OB case. The case is a patient who has some complications, advanced maternal age, obesity, an abnormal NIPT. The patient had management for these different complications, which is listed in great detail in the procedures and treatment column. She also had a postpartum complication, postpartum hemorrhage, and the management of that is listed as well. And what we've done here is we have taken the ABOG approved abbreviations. You'll see I've highlighted those in yellow for you: AMA, BMI, PPH, AROM, SVD. I would recommend that you get familiar with the common approved abbreviations and use them in every single case, everywhere that they are appropriate, okay? You'll also notice that I've included a couple of non-ABOG approved abbreviations. Personally, I think that these three abbreviations are very common: NIPT, MFM, and IUPC. And I would feel comfortable using these abbreviations. And again, one of the things that can help you when you finish your case list or come close to finishing is to have a formal review of your case list. And when you do, if you have non-standard abbreviations or unfamiliar abbreviations, those will be called out by your reviewer. We do offer that service here at ExamPro. I think it's invaluable to do a case list review once your case list is pretty much complete so that you can fine-tune things like non-standard abbreviations. You will also notice in this slide that I pointed out some what I call summary terms. Okay, so what I call summary terms are things like obesity management. And I'm going to go back to the previous slide, because in the previous slide, you can see that things that might be considered obesity management: early 1-hour glucose challenge test, counseling on weight gain, serial ultrasounds for fetal growth. They're listed individually. Now, part of the reason that I like summary terms is because they make it easier to convey information, so it's easier for the examiner to read. And they also set you up to be asked for more detail. Well, when you say obesity management, what are you referring to? And I think that these are things you can easily remember. And if you're preparing after you've finished your case list, you'll practice these and you'll easily be able to say, well, I would do a 1-hour glucola early for a patient with obesity. I would be focusing on weight gain counseling. I would also be thinking about serial ultrasounds for fetal growth, especially in the second half of pregnancy, in the third trimester particularly. So obesity management is a summary term. Antepartum surveillance is another summary term. I would love to be asked by the examiner what I did for antepartum surveillance, and I could talk about my approach when I started it, what particular tools I used to do it: BPP, NST with AFI, et cetera. And then at the bottom of this entry, you see uterotonic medications. And this is, again, another summary term that's very important. If you list that you gave Methergin, and I think on the previous slide, I'll go back to it for a second, Methergin, Hemabate, and Cytotec, Well, there's no reason for the examiner to ask you about your uterotonic medications because you've already listed them. So make the list easy to read and promote some questions that are relatively straightforward, and then prepare to answer those questions because you can, of course, predict you might be asked. Summary terms, they save space, they promote questions. I think it's a great approach. And when you use these summary terms, we're going to talk in a second about consistency of terminology. Go through your list, and in every case where you have an obesity and obesity management, use the same summary terms so that the list looks complete and carefully put together. All right, I'm just going to touch on a few more abbreviation slides. I find that a lot of the approved abbreviations are overlooked, and I want to make sure that you don't overlook them. So here's a few really common and often overlooked abbreviations. SVD. Any delivery that you perform that's not a cesarean delivery or a vacuum or forceps delivery is essentially an SVD. You even have an SVD when you have a shoulder dystocia, because the shoulder dystocia is a complication that occurs after the delivery starts. So again, SVD, CD for cesarean delivery, TVH for total vaginal hysterectomy, PTL for preterm labor, US for ultrasound. I can't tell you how many times I see inconsistent use of terms and abbreviations related to imaging, and particularly for ultrasound. US is the abbreviation ABOG prefers for ultrasound or ultrasonography or sonogram. BTL for bilateral tubal ligation. I will note there is not an abbreviation for bilateral salpingectomy. Some people will use the abbreviation BS, and I think that sounds a little funny, BS, but not that BS. The BS, bilateral salpingectomy. I think that has kind of taken root, and I think if you do use that abbreviation, you will be fine, but many people do write out bilateral salpingectomy still. For any early pregnancy loss, this would include missed AB, spontaneous AB, complete AB, or even a voluntary therapeutic or elective AB. The abbreviation AB for the word abortion is ABOG approved and should be used. And when you do a DNC, D with the ampersand, which is the and symbol, followed by C. Those are capitalized, of course. This is an approved abbreviation. Now, one of the other prerequisites on your GYN list is that when you do a hysterectomy, ABOG asks that you list the weight of the uterine specimen. And some people don't know that, so I'm going to point that out, make a note to yourself there. And when you do list that weight, use the abbreviation GM for grams. That's ABOG's approved abbreviation for gram, GM. So I encourage you to use these abbreviations every chance you get. And I love it when I see a candidate who's already doing that when I'm doing a review of their case list. What about other abbreviations? I already mentioned that there are common abbreviations that are not necessarily in the approved list. I think you have to use caution and good judgment. The more consistent and common the abbreviation is in clinical practice, the more likely it will work. So for instance, DNA, IUPC, and BPP, all of these are not on the approved list. They're all commonly used. I see them on case lists. They don't bother me. I think they're actually helpful. Try to avoid certain casual abbreviations like H/O when you're saying history of, or S/P for status post, or W with a slash for with, or W/L for normal. In fact, I'm going to tell you, you really don't very often need to say normal because normal results really don't add much to the case list. I'll talk about that in a minute. I think it's always important to put pertinent positives into your case list, but it's not very helpful to list a bunch of normal tests and normal results. And again, when you do put stuff in, try not to use these casual slang abbreviations. Write out the word history of, or you can use a word like previous to indicate like a previous CD instead of history of CD. And for that matter, when you have a patient who's a G2P1 on your OB list and her first delivery was a cesarean delivery, you can say history of CD and you don't need to say ×1 because she's a G2P1. We know she could only possibly have had one previous cesarean. Now, if she's a G3P2, and she had one cesarean and one vaginal delivery, then you should say history of CD ×1. Or if she's a G3P2 with 2 cesareans, say history of CD times 2, a little X and the number 2. And these type of abbreviations work out very well. Again, write out history of or status post or use the word previous instead of using these casual abbreviations. So abbreviations, I think I've covered this. I'm going to move on to what I call standardizing your terminology. So this is my next section on how do I optimize my case list. Standardize your terminology, keep simple cases simple, strike a conservative tone in the way you describe your cases, and prep your pathology. I'm going to cover each of these in more detail. First of all, standardize your terminology. Having a variety of pathology and topics is a high priority for ABOG on this exam. You can't really take the exam if all you do is tubal sterilizations and you don't do any other surgery and you don't do any other, OB or office, but none of us are doing only one thing. With this in mind, what makes your list interesting and comprehensive is different patient demographics, like different ages of patients. So for instance, when we think about preventative visits, if a patient is 30 and another patient is 31, they're going to have basically the same stuff. But if a patient is 30 and another patient is 65 and you put both of them on the list, it's going to be different because the demographics make the issues that are relevant different. Okay, so different patient demographics is one way that we increase the variety of topics and pathology on our list. Unique diagnoses, and these can be unique diagnoses that we made, or they can be unique diagnoses that were unexpected, or they can be unique diagnoses that are in a patient's history. And sometimes we can incorporate an interesting discussion into the exam when we didn't actually manage that problem, but we're aware that the patient has that problem in her history, and we'd like the examiner to ask us about that problem, so we include it in the history. Comorbidities. Comorbidities are sort of like unique diagnoses, but they often are things that are related to the problem we're managing, so they're important to mention. I'll give you an example. A very common comorbidity in my mind would be hypertension, which can be associated with a lot of different OBGYN treatment plans. Another comorbidity might be a patient who is pregnant and has BV. Okay, so again, or chlamydia. And so comorbidities, which may not be the main reason we were treating the patient, but they are other diagnoses that are important, either because of risk or because they need to be managed. Appropriate management strategies. Now, you may be scratching your head. What does he mean here? What I mean here is that for any given diagnosis or any given patient problem, there are multiple different management strategies. So one thing that makes your case list interesting is when you have a patient with the same problem, she may even be a very similar demographic to another patient, but the management strategy that was employed is different. And the natural question in the examiner's mind, and this is great for you when you're building your case list, is why did you manage this patient differently? Because on the case list, I can't see any reason that you had to do this differently. And that's one of the wonderful things about OBGYN that makes the exam interesting and fun. And I know you're not thinking it's fun. I apologize. I'll try not to say that again. But if you get enthusiastic about preparing for this exam and your case list, I think it becomes a little bit less painful. I'll just say that. Again, with management strategies, we've got a lot of different ones. And you can prepare to talk about why you did a bilateral salpingectomy for one patient and maybe a fallopian ring tubal ligation for another. And I'm using an example that probably most of you don't have. Again, forgive me, just off the top of my head, trying to make a point. Outcomes and complications are another area of variety. So no, we don't always get the outcomes we desire. And we sometimes get complications, which I would consider to be untoward outcomes that we'd like to avoid. And these make cases interesting. They are a particular focus for the exam. So when you have unexpected outcomes or complications, we want to make sure that we manage these on the case list in a way that will generate discussion that we can predict, questions that we can predict, and that will also present our practice of OBGYN and management of those complications in a favorable way. Okay, so let me just get to where I was going with all this. Using different terminology to describe the same thing on different patients is not variety. I'll show you an example in a minute. So decide on your preferred terms So for a particular problem, I'll give you an example. If you on your case list in the OB section are going to list obesity as a complication, which I think most of us would as an antepartum complication, you could list obesity, you could list BMI and then the number. Whichever way you want to do it the same way all the way through your list. Every patient with obesity, list their BMI with a number or list the word obesity. And then in the treatment column, put obesity management if that's how you're going to do it, but do it the same way on every case. Using different terms. On one case, you call it obesity. On another case, you call it BMI 45. And then in the management, on one case, you say obesity management. On another case, you list a couple of things you did, but you don't list the same things on each case. It's just not put together. It doesn't look professional, and that's not how you get variety. That's just sloppy. Okay, so a couple of examples that I see, common examples that I see on case lists, where on one person's list they'll use different terms in different cases to describe the same thing. Here's a couple of the really classic ones: diabetes in pregnancy, and I'm talking about gestational diabetes, okay? Because we could talk about pregestational as well, but with gestational diabetes, there's a lot of different terms that people use: GDMA1, GDMA2, or gestational diabetes not on medication, gestational diabetes on medication. So again, pick your term. I prefer GDMA1 or A2 because that's an approved abbreviation, GDM, and everybody's familiar with A1 versus A2, diet controlled or requiring medication. But one thing about the case list is that you don't have to use GDMA1 or A2. You can talk about it, gestational diabetes, but if you do, be consistent. That's where I'm going here. Standardize your terminology. Thyroid hormone deficiency, another example where you could call this hypothyroidism, which is what I would call this. But you could say maternal thyroid disease or elevated TSH or abnormal thyroid function. The key here is if you're talking about the exact same thing, if you have two patients who both meet the criteria for hypothyroidism, and you're not trying to distinguish a clinical condition that caused it, okay, you're just trying to say hypothyroidism and call them both hypothyroidism. And so here's an example of an OB list with some sloppy terminology, just to kind of show you what I'm talking about. We have 3 OB cases. In this, I've put them all in a row so that you can see this. And the first one has GDMA1, and everything else is consistent. The second one, when I say everything else consistent, the treatment column across all 3 cases is fairly consistent. The second case is listed as gestational diabetes. We don't know if this is A1 or A2. And so if this is all on the same list, it's, kind of difficult for me to figure out, well, what's going on in this case. The third one says GDM on medication. So this would be essentially GDM A2. It happens to be a case of recurrent GDM. And in the history, they say history of gestational diabetes, but when they say recurrent GDM, they say GDM. So again, use abbreviations, use them consistently, pick your term. It doesn't matter which of these 3 entries you choose. I would prefer the top one, and personally for me, and the second entry is not as informative, if you will. It doesn't tell me A1 versus A2 because there's nothing I can see on the case list to inform me. But pick one and be consistent. Now, I do want to point something out that might be subtle and not apparent to you at first on this slide. You will notice that all 3 patients have diabetes management listed. Clearly, the first case is a diet-controlled gestational diabetic, but we still do some management. We counsel these patients about diet, and we talk to these patients about checking their blood sugars, and we monitor their blood sugars. So there's definitely diabetes management in every single one of these cases. If you go to the third case, you'll see that this patient is on medication, and I generally favor listing the medication that the patient is on, because that is something that goes above and beyond the other diabetes management that we do for the patient who doesn't need medication. So again, this is just a subtle point that I think makes your case list very complete when you do it this way. But there's some style involved here, so you have the latitude to decide that you might not do it exactly the way I'm suggesting. All right, let me mention a few other standardized terminologies. I mentioned the abbreviation US for ultrasound. I prefer that abbreviation. ABOG has approved that abbreviation. but you might choose to call it a pelvic ultrasound or a pelvic sonogram. It doesn't really matter as long as you're consistent on each case. If you have 3 cases in a row and one of them you call it a pelvic ultrasound, and the second one you call it a US, and the third one you call it a sonogram, it's inconsistent. I think I've made the point. I'll stop with that. I do want to also point out that one problem with ultrasounds and imaging is either too little information or too much information listed on the case list. So, for instance, if you have an ovarian mass or cyst, it would be appropriate to describe the dimension. So I'll see somebody, will say US complex ovarian cyst, but it won't tell me the size, okay? I'll also sometimes will see where somebody tried to copy the entire radiology report into the case list. And it'll go on and describe a bunch of different little features, and you can suffice to say complex, and you don't have to describe all of the features that made it complex. You can talk to the examiner about what you would consider to be complex or concerning findings on a pelvic ultrasound when they ask you that question. And also on this slide, we have endometrial biopsy. This is another common one where people will be inconsistent. On one case, they'll call it an EMB. On another case, they'll say endometrial BX or whatever the case may be. And by the way, BX is not an approved abbreviation, but some people use it, and I think most people know what it means. A few more examples. Management of obesity and pregnancy. I already hit on this. The summary term obesity management, I think, is very nice here, but there are other ways that you can state this. Whatever your approach is going to be, whether you're going to list individual items or whether you're going to use a summary term like obesity management, be consistent. And then when we get to antenatal surveillance, this is another area where very commonly people are not careful and their case list will have a bunch of different entries referring to the same thing. Or some people won't list antenatal surveillance at all. And I think there are a lot of cases where antenatal surveillance is important and not listing it. You could always volunteer it verbally, but it's nice to mention it when you have a complication that justifies it. And then we get to induction of labor. There's a variety of different ways you can describe this. I will point out admission for induction of labor at term is not only wordy, but it's redundant, because on the case list, the gestational age is an entry that you have to put in. And the gestational age they're talking about is the gestational age at admission. So you don't have to say induction of labor at term because it's going to say 39 weeks or whatever the case is. And so you can just say induction of labor. Patient requesting sterilization. She could have undesired future fertility as her pre-op diagnosis. She could have request permanent sterilization. She could have desire sterilization. Just be consistent. And many of us have multiple sterilization cases on our list. I'll talk in a few minutes about keeping simple cases simple. These tend to be simple cases. There's no reason to have a bunch of inconsistent terminology or excessively wordy entries for a case that is essentially a minor gynecologic surgery, unless there was a complication or some extenuating circumstance. So, continuing on, how do I optimize my list? Moving to keep simple cases simple. Let's just look at this, and this is fairly straightforward. Here is an example of one of the types of cases that most candidates have on their list that are generally fairly simple cases: suction D&C for early pregnancy loss on the GYN section of the list. So here you have the incomplete, septic complete, and other abortion category. You can see that at the top. And then you have 3 cases that are listed. This is an actual way that these cases were entered into a real case list. Now you'll notice that they did use the abbreviation DNC, but you'll also notice that they did not use the abbreviation AB for abortion. Okay, so I would have called this incomplete AB, missed AB in each of these cases. But I will give credit here. This is a very simple and clean entry. These are not difficult cases. These patients were not admitted. They had no complications. They had very straightforward presentations, okay? Now, some people will try to define a missed AB on paper, but that's a wonderful question to talk about in the exam. How did you diagnose this missed AB? And then you get into the patient's presentation, the criteria for a missed AB, which you should be familiar with. They are listed in the ACOG practice bulletin on early pregnancy loss. So again, these are straightforward and relatively easy cases, and they should look clean and simple on your list. Now, there are sometimes additional pieces of information you might include. If a patient elected to have a chromosomal analysis or a genetic analysis on the products of conception, then you might include that information for a case where that was performed. If the patient had a complication, like she got a blood transfusion, of course, you're going to include that information. But in most of these cases, the cases are not complex and they don't need to be complex on paper. Okay. Now let's go to this one, induction and augmentation of labor. So this is a very nicely done section on induction and augmentation of labor. This list shows that there are a few complications that have been sprinkled in here, and the management is consistent with the various complications that are listed. But this is easy to read, and there are 6 cases on this single page of a case list because the candidate has kept these cases clean and simple. Okay. I can glance briefly at the nights in the hospital for the mom and the baby. I can see there are no extended hospital stays. So again, this is another important point. Some cases are not clean and simple. If a patient had a prolonged induction and was in the hospital for 5 or 6 days, if the infant was in the hospital for 10 or 14 days, there's probably more to the story. And so we need to make sure that we include whatever information would explain the data that we have listed on the list. But many of these induction augmentation cases are very simple and straightforward, and I would encourage you to keep them clean and simple and be consistent in your terminology. I will point out on this case list, this candidate did use GDM-A1. I like that. They used NSVD. Now for ABOG's purposes, their approved abbreviation list doesn't include the letter N, it just uses SVD. So one comment I would make is to make the abbreviation SVD on every one of these deliveries. And then I think this is the last keep it simple example that I have for you, a very, very common one. Just about every candidate, unless you're practicing in a hospital that doesn't allow sterilizations to be performed, just about every candidate has multiple sterilizations on their list. And so for most of these cases, they're not controversial, and there's really not a lot of material that needs to be listed. You have the indication, which I talked about that there are different ways you can describe that. In this case, it's been described as desire sterilization. You have the procedure itself. These are all bilateral septuncectomies. I suspect for many of you, this is exactly how your sterilizations will look because you're doing mainly bilateral septuncectomies. And for the pathology, it always amazes me how sometimes for a candidate's sterilizations, the pathology column will be huge. But when I read all of the information they've listed, it's basically saying benign fallopian tubes. Okay. By the way, when you say fallopian tubes with an S, you don't need to say benign bilateral fallopian tubes because there are only 2. And if there's an S on the word tubes, then I know that we got both. Okay. So there can occasionally be complicating factors for a sterilization case. When there are, they should be listed. Let me give you an example. You might have only performed a left salpingectomy. Now, the usual reason is the patient only has a left fallopian tube. So you might add to the pre-op diagnosis history of right salpingectomy for ectopic pregnancy or whatever the case may be. And you could just, if you want to put history of salpingectomy, or some people even will say, I'm not going to list anything. I'm just going to put in the procedure left salpingectomy and left fallopian tube for the pathology, and I'm going to make them ask me because I want to talk about the patient's history. That's fine. There are a lot of different ways this can be done. The point I'm making is most sterilization cases are simple. Keep them clean and simple, okay? So let's go to the next important point. Strike a conservative tone. What am I talking about here? Well, I'm talking about the fact that when I look at your OB list, if every patient who was a candidate for a trial of labor, this would be a patient who had, say, 1 or maybe 2 cesarean sections in the past, and she doesn't have any history of uterine rupture or any other complicating factors that would preclude her having a trial of labor. So if every patient who's a candidate has in the antepartum column declines trial of labor, or perhaps in the procedures or treatment column, you choose instead to list TOLAC counseling. And I do think TOLAC is a reasonable abbreviation you can use. But again, if every patient who's a candidate has this mentioned, as I'm reading your list, I'm thinking, oh, this is a conservative style of practice that you talk to patients about the option for trial of labor. Now I want to stop for a second because there may be some of you listening who don't offer trial of labor in your facility. That's okay. You're still going to have this conversation with a patient, at least a very brief conversation about the fact that you don't offer that. If she's a good candidate and motivated, she might seek a trial of labor in another facility. Okay. So again, instead of saying request repeat, which is kind of like the patients in a drive-through window asking for tomato and onion on their burger, instead, we're going to say declines trial of labor, which is, I always think about if the patient's a candidate, that I want to discuss this with them, okay? The same thing when we talk about induction of labor. There's no reason you have to put in elective induction. I mean, with the ARRIVE trial, so many people are doing elective inductions, but you don't need to write the word elective. The examiner can look at the case. They can see, if there's no medical indication documented that this was likely an elective induction, and they might ask you, why did you do this induction for this 24-year-old G1P0 at 39 weeks and 0 days with no complications? And this is a perfect opportunity for you to talk about the fact that the patient preferred to have that induction. It was done basically electively, but again, you get to talk about what goes into that decision, the counseling, the pros and cons. And I don't think you need to just write elective induction, elective induction, elective induction on all of these cases on your list. Let the case speak for itself. It's a more conservative approach. When we think about a missed AB, you can put request surgical management in the pre-op column, or you can put counseled on treatment options. And when you say counseled on treatment options, to me, what this makes me think of, and a lot of this is about psychology. As an examiner, it makes me think, the options that you counsel the patient on were probably expectant management, medical management versus surgical management. And in fact, when I see counsel on treatment options, it makes me want to ask you, what treatment options did you counsel the patient about? And so these are just a few examples of how you can strike a conservative tone with the terms that you choose to use on your case list. And it's describing exactly the same management or the same diagnosis, but just using terms that take a more conservative rather than a more aggressive sort of mental imagery. They produce a more conservative mental imagery in the examiner's mind. And I think this is really important, setting this tone as you go through the preparation of your list. Okay, so the next thing I want to talk about is prepping your pathology. The surgical pathology column on the GYN list is exactly for surgical pathology, okay? So whenever you remove a body part, an organ, a tissue, it should have a pathology result, even if it's just something simple like benign fallopian tubes, like we talked about for the bilateral salpingectomy case. Now, if you have a case where you don't remove any tissue, then ABOG is going to ask you to state the final clinical diagnosis in that surgical pathology column. And as I've already said, any organ removed should have a result listed. So here's a few examples. You do a case for endometriosis, but you do not do a biopsy or remove any tissue. Do not describe the appearance of the lesions in the surgical pathology column. That is not required. You simply state the clinical diagnosis, endometriosis, in the surgical pathology column, okay? Example number 2, you do a hysterectomy with a BSO and the pathology is completely benign. Well, you're going to want to include the uterine weight. So you might say uterus, 300 gm for grams. Any notable pathology that the pathologist mentioned. So you might say adenomyosis or leiomyomata or multiple leiomyomas. And then you might include a benign notation about the endometrium and cervix. A lot of people do. They'll say benign endometrium and cervix. And then an entry for the adnexa. Because you did a BSO, I expect to see something in that surgical pathology column that mentions the ovaries and fallopian tubes. And if they were completely benign, it'll say something like bilateral ovaries and fallopian tubes benign, or benign fallopian tubes and ovaries. The word bilateral not necessary if you actually removed both and you have the letter S after ovaries and after tubes. But again, the point I'm making is I see a lot of times where a structure is removed, like a fallopian tube or possibly an ovary, and it's not mentioned in the pathology column. Now, one very important point about keeping your list clean and simple: please do not try to copy the pathology report verbatim into the surgical pathology column. Summarize the pathology in a concise bullet point type of format. Now, one of the things that has helped this along, the idea of summarizing your pathology, is that there are now restrictions on how many letters or words you can enter into a given field on the case list entry software. And so a lot of people are getting better about summarizing stuff because they can't just cut and paste the entire report. But even if you have enough room for it, I don't recommend it. Clean up the pathology, summarize it. Now, any pertinent positive, any abnormal, unusual result should be documented. So please, you don't want to leave off a cancer diagnosis or even endosalpingiosis or chronic endometritis. I think those are abnormal results that you would like to mention, but you can mention them in a very concise way. So a few more suggestions about how to optimize your list. I want to talk for a second about necessary versus unnecessary information and eliminating some of the unnecessary stuff. And then we'll go on and we'll talk about prudent use of special effects, and I'll explain what that means. So first of all, looking at necessary versus unnecessary information, let's go to this next slide. There are several common ways that I find candidates include unnecessary words or information in their list. One is that they'll restate the diagnosis that's listed in either the pre-op column or the antepartum complication column. They'll restate the diagnosis in the treatment column and I'll show you an example, by saying something like cesarean delivery 4 or hysterectomy 4. Well, I already know why you did it, because in the other column, you told me what that diagnosis is. I'll show you an example in just a second. Another thing that we do, which is not helpful, is we will list tests and evaluations in great detail. I tend to favor using summary statements, for instance, preeclampsia labs, okay? But even if you're going to list the individual test you did, you do not need to go through and then list normal results. And so in the office list, I will see this a lot. Somebody will list a PCOS evaluation and they'll list all the tests they did. And they'll have the 17-OHP and they'll have the testosterone, all the tests they did. And then over in the results column, they'll list all the normal results. Okay, so this is just redundant, unnecessary information. And I know for a lot of candidates, they think they're being thorough, but what they're really doing is making it more difficult for the examiner to weed through all that unnecessary information to find what was actually pertinent and positive in the evaluation. Okay, so if you are going to list the individual tests in the diagnostic procedures column of the office list, you only really need to list the pertinent positive results. You can list those in the results column, or you could list the tests in the diagnostic procedures column and put a little notation next to each one that was abnormal with what that result was. There's a variety of different ways you can do this, but the key thing you don't want to do is list a bunch of normal results in the case list because they just kind of clog it up and make it harder for the examiner to follow. So let me just show you an example slide. This is really getting at the restating the diagnosis, and there are a couple of other things on this slide that I will point out. But you see in the first column where we have the big blue arrow, you see a little red arrow next to history of cold knife cone, and then you see short cervix. Okay, so short cervix is what we're pointing at with that red arrow. You go over to the treatment column and you see increased antepartum surveillance for short cervix. Okay, we don't need to restate the diagnosis. You can list what you did, and any examiner will understand that, oh, okay, this was increased surveillance because of the short cervix. And if they don't, guess what? They're going to ask you a question. Why did you do the increased antepartum surveillance? Fantastic, because you're prepared to answer that. You know why you did it, and you don't need to restate the diagnosis over and over. Now, when you look at the next little red arrow, down in the first column, it says intrapartum chorioamnionitis. Then we look at the treatment column, treatment of intrapartum chorioamnionitis. I would prefer instead to just say in the treatment column, antibiotics. And that's all you have to say. Just say antibiotics. And then if they want to ask, well, what antibiotic did you use? Fine. So again, you don't need to restate the diagnosis. I think I've made it very clear. There are a couple other things I will point out about this case that I think are interesting. The green arrow in the top of the treatment column is pointing at intarvaginal. Okay. This is unfortunately a spelling error, and it's not a big deal, but when you have a bunch of spelling errors on your list, it does look like you could have done a little better job. So we want to put our best foot forward, and this is, again, another reason I do encourage candidates to consider a formal review, but also when they are compiling the list and entering the data, be careful, look at it carefully. Now, the other green arrow in the treatment column has, it's supposed to be pointing at workup for preeclampsia, and it looks like it's pointing instead at IOL. I'll comment on both of these. IOL is an abbreviation some people use for induction of labor. It's not an approved abbreviation. I generally don't use it, but I think it is clear enough that everybody knows what it means. I tend to just write out the words induction of labor. But what this arrow is really supposed to be pointing at is workup for preeclampsia. In the antepartum column, if you look at the other green arrow going back to the left, you see pregnancy-induced hypertension. So what this green arrow is really getting at is this person in one single case has used inconsistent terminology. Okay, pregnancy-induced hypertension is an old term that used to be used to describe preeclampsia. So if you wanted to, you could say hypertension, you could say elevated blood pressure in that antepartum complication column. And then, of course, the workup was done. But if you're trying to say the patient had preeclampsia, then you can just list in the antepartum column preeclampsia instead of pregnancy-induced hypertension. So again, be consistent with your terms. All right. This is an example of a case that perhaps I would consider has too little information. And so the point I want to make here, most people are erring on the side of including unnecessary information, but occasionally I see candidates who leave something out. And what I mean here is that the amount of information on the case list should really correlate with the clinical complexity of a case. In this case, we have a G1P0 at 37 weeks who had a intrauterine fetal demise. So the thing about this is she had a pretty significant bad outcome, and it's not really clear to me what exactly happened. It seems like an incomplete case. If I had an IUFD at 37 weeks and a G1P0, then I probably wouldn't do an emergent cesarean delivery unless I had hemorrhage or, from the placental abruption, or unless I didn't know, I thought the baby might be salvageable. So again, I think this case could have a little bit more information. You can ignore the notation, the red marks on there. I did not pull this case for anything about that. That's just a notation reminding somebody of the birth weight. I mean, not the birth weight, well, it was the birth weight, but of course it was an IUFD exceeded a certain percentage. That's not relevant to my comment here. My comment is that this is a fairly complicated outcome that's being described in perhaps a slightly insufficient manner. Okay, so sometimes we need to put a little more information. All right, now, one other thing I want to touch on when I talk about unnecessary information, I want to talk about unnecessary cases. And I want to comment about volume of cases, okay? With OB and GYN for your list, you need 20 cases minimum to take the exam. And 20 cases is more than adequate. So if you have 27 or 28, it's not any better than 20 as long as you have the minimum number and you have no more than 2 cases in each category. You'll see when you read the directions from ABOG that you can only list 2 cases in each category on the case list. So sometimes people get worried about volume, and they worry about the low volume, and they start collecting cases by scrubbing in on their partner's cases when they really didn't work the patient up and they didn't primarily manage the patient, they were simply assisting. And so if you were assisting your partner and you start to list their cases, what you often find when you go to prepare for the actual exam is that you might not have managed that patient the same way, or there's something in the case that makes you look bad, and you weren't even the one who did it. And so be careful. Adding in your partner's cases to simply try to bump up your numbers is not the best way. However, co-management does count, and those cases should be listed. What is a co-management case? Well, this is a case where your partner couldn't do the case, so you stepped in maybe. I've seen this where a partner was ill or injured and they couldn't perform a surgical case, so you picked it up. It was your case. In that case, you might have some things you would have done differently, and that makes a good opportunity to discuss management issues and decisions about management in the exam. And I'm not going to go into more detail about that, except to say that if you actually did the case for your partner, it counts. The other thing is when you did part of the case, and this is really the true co-management. Say you did a hysterectomy and your partner came in and did a sling procedure because the patient had incontinence. Well, you're going to list the patient on your list. The hysterectomy is yours. And in the treatment column, you're going to list sling procedure, and then you put in parentheses by colleague or by partner. Okay, so that's okay. But what I really want to make a key point about is don't try to collect your partner's cases when they really weren't yours, because it doesn't really make that big of a difference and it usually hurts you. Okay, so just assisting on a case does not make that your case. Now, the other thing that sometimes comes up about unnecessary cases on the GYN list is when one patient is listed twice. Okay, there are very few situations in which the same patient should show up on the GYN list twice. I'll give you one little disclaimer. If a patient was admitted to two separate facilities, sometimes the facilities will require you have to list the patient separately because the facility numbers are different. Okay, but that's rare. Most people are operating in one facility. That patient was only operated on in one place, but she might have had an endometrial ablation in the first month of your case collection year and wasn't happy with it and came back in the last month of your case collection year and had a hysterectomy. If she did, she only needs to go on your list once. You can enter her for whichever category you want, and then you'll have a line space between the two separate episodes of care, okay? And so if you need help with a case like this, we're always available to help with this, but the bottom line is that the patient only needs to go on the list once in the vast majority of cases, and so having a second entry becomes confusing or difficult to explain sometimes in the exam. All right. The last thing I'm going to talk about optimizing your list before I get to a case list construction thing that will kind of be my ending point. I want to talk about prudent use of special effects. Now, I know that some of our other faculty that are participating in this course, and I believe you will be listening to all of our lectures in a sequence, are going to talk about some special effects that you can use to highlight information on the case list. And when I talk about special effects, I'm talking about things like using all caps or bolding an entry or putting exclamation marks. So let's talk about this for a second. I think special effects can be useful if they're used carefully. And so let me just go over a few things here. First, there must be a point to be made, okay? I would think if you're highlighting something, it should be something interesting and significant. And if you're highlighting something that seems like kind of a no-brainer, then that sometimes leads me to wonder why you highlighted it. Maybe you are making more out of something than it should be. Okay, so that's the first thing. There should be a point that you're trying to make with it. If you overuse a special effect, so if you have 30 cases on your GYN list, I'm just making up a number, okay, and 15 of them have bold print in the case, it starts to become routine. My brain starts to ignore it when I'm reviewing your list to think about asking you questions, pretending to be the examiner here. I see bolding everywhere, so it's not really useful. It's not helpful. And I want you to start, I'm going to show you a series of different similar cases to make this point. Start by looking at this case. This is a 36-year-old G0 diagnosed with, in the pre-op column, AUBO. So this tells me abnormal uterine bleeding associated with anovulation. She has obesity. Both of these first two diagnoses are risk factors for endometrial cancer, so that would certainly be in my mind. She failed medical treatment, okay, and that would be a reason to proceed with sampling. I would often do this in the office. It's been clearly documented by this candidate that she declined an office biopsy. And so the patient went for a hysteroscopy D&C. and the pathology showed endometrial cancer. Now, we could argue about could you be more specific in the pathology about the endometrioid and the grade of cancer if it was given. I think that it's nice to be specific with a diagnosis in the pathology column. You don't have to have the whole path report, but you could maybe be a little bit more specific. But this case is not unusual. The point I'm making here is that the patient was then referred to G1 oncology. So I look at this case and I think, wow, it's straightforward. She had risk factors for endometrial cancer. You did a sampling procedure, you got endometrial cancer as the result, and you sent her to G1 oncology. To me, this would not be the case where I would use special effects. But let's look at this case. Here, this is a slightly different case. She's the same age, 36. She's a G2P2, but the pre-op diagnosis is heavy menstrual bleeding. That's not necessarily a risk factor in the same way that AUBO or obesity are for endometrial cancer. It says failed medical treatment. That's a good reason to do sampling. And it says that the ultrasound showed an endometrial polyp. So we have a presentation that suggests a benign lesion. We, of course, would do a hysteroscopy DNC polypectomy. I think that's very straightforward. And lo and behold, we got type 2 endometrial cancer. Now, in this case, I think it's a little more justifiable to use a special effect. We're trying to draw attention to the unexpected and somewhat more significant diagnosis of a type 2 endometrial cancer. Now, the way it's worded would lead me to, if I was an examiner, to think about asking you, well, what is a type 2 endometrial cancer? And you might choose on your case list, instead of saying type 2 endometrial cancer, to list the specifics of that diagnosis, the cell type of that cancer, the histologic type of that cancer, and that would be fine. But the point I'm making here is that this case makes a little more sense for using a special effect. Then let's look at this one. It's the exact same case as I just showed you, but instead of bolding the pathology, 2 exclamation points have been added. Okay, I see that, I get it. We're saying that you weren't, to me, it says, I wasn't expecting this, and I think it's interesting. And the whole point of a special effect is to draw the examiner's attention to that particular piece of information and hopefully generate questions about it. Let me go to the next slide. One more variation on a theme. Here, the pathology has been all capitalized instead of being bolded or having the exclamation points, but it's otherwise the exact same case. I think each of these are different methods of emphasizing a piece of information on your case list. Again, they can be appropriate and helpful so long as there is a piece of information that's worth highlighting or a particular set of questions that you're trying to provoke. And as long as you don't do it over and over and over on every single case, because when you do, it starts to lose its effect. Now, the last slide, I just combined all 3, all caps, bold, and 2 exclamation marks. I would argue this probably isn't necessary in most situations. I would reserve this for something really important or unusual, or for a situation where you have presented a case, and I know that some of our other faculty are going to talk about this, in a way to try and purposefully provoke a discussion that might not happen if they don't notice this piece of information. So again, I think this is probably not necessary. In most cases, you can use one special effect. You don't need to use multiple, but once in a while, it might be relevant. Okay, so here's this last slide. Here's an example of a page on a case list where you have 3 different cases, and in each case, something has been bolded. And I wanted to make a couple of points about this. First of all, if every case on your list has bolding, you're overdoing it, okay? It's not exclusive to the pathology. You can bold pathology, you can bold a treatment. In this case, preoperative Lupron is bolded in that second case, which might be a very nice discussion about the management of a patient with symptomatic fibroids and chronic anemia, okay? Interestingly enough, in that case, the ultrasound findings of the myomas, the size and location, it's not listed in the pre-op column. Again, sometimes you can add a little bit more information. It can be helpful depending on what the situation is, but I'm not criticizing it. I just wanted to make the point that bolding can be for pathology, bolding can be for treatment, bolding can be for a pre-op diagnosis, like in this last case, contraindication to OCPs, What contraindication to OCPs? Well, maybe antiphospholipid antibody syndrome. That might be a good one. So maybe you want to stimulate a discussion of antiphospholipid antibody syndrome in the sterilization part of your case list by highlighting or using a special effect, bolding, capitalizing, underlining, or exclamation points about the patient having a contraindication to OCPs. And I know we're going to expand more about the different wording. You might be saying, why not just list antiphospholipid antibody syndrome? And I'm just going to say that when you do something the way it's done here, and like this candidate did, you increase the chance they'll ask you, because the natural psychological reaction of the examiner is, what contraindication to OCPs? Okay. But my point is, in summary, don't bold every case because it loses its effect. And the bolding is not exclusive to only one column of the case list. Depending on what the information is, it could be useful in more than one column. All right, so this brings me to the part of this presentation that is most near and dear to my heart. This is, I think, the most important advice that I give candidates about constructing their case list. It is a personal pet peeve of mine. Pet peeve meaning a missed opportunity for most candidates, not something I think people do wrong, but something I think people miss a huge opportunity on. And it's the office list. So I'm going to focus exclusively for the remainder of my presentation on the office list. The point that I want to start with is that the office list should be your easiest list to prepare, and it should be the section of the exam that you look most forward to being examined on from your case list standpoint, okay? Now, the structured cases are a little different because the office section is so broad, and it can be primary care, and it could be infertility, and it could be pediatric gynecology. I mean, there's so many things. The structured cases, I think, are a wild card. But remember, half of the hour is based on your case list, and this should be your best section or your most eagerly anticipated section. Why? Well, here's why. Remember that in the office list, you're going to have 40 patients, only 40, no more, no less, and you can list, the word can is important here, ER patients, L&D triage visits, virtual office visits, procedures you perform in your office, as long as they're not on the OB and GYN lists. So the point I'm making is you get to include anything you want, and you get to exclude anything you want. So if there's something you don't want to talk about, I'm always amazed when I see an office list with a case of primary amenorrhea. The first thing that enters my mind is it's probably a reproductive endocrinologist, because I don't think any generalist would by chance choose primary amenorrhea. The second thing that enters my mind is that it's a generalist who wasn't thinking when they made the office list and wants to have a really hard discussion if the examiners choose to go there. So again, my point is you can include anything you want, you can exclude anything you want. The structured cases are fair game. That's, you can't control that. But the office cases that you list, you can control. And there are so many options. To me, it's just an opportunity begging to be optimized. And the main reason people don't is because they wait until the end. They aren't creative with their thinking about how to make the office list. And so they end up just stuffing stuff in there, and then they submit the list, and then they spend the next 2 or 3 months struggling, worrying about how they're going to prepare for those cases because they weren't the cases that they really should have chosen. Okay, let me give you some more detail to make this easier. You are now beginning your case list preparation process. You may have already started preparing your office list, but if you have, stop. And before you gather any patients or any more patients, I want you to make a list of as many different topics in OB/GYN that you would like to discuss. Okay, so just put all your patients aside, just sit down. This doesn't take very long, and start thinking off the top of your head about topics. And I made it easy here. I started with a high level approach. So high level approach means I started with kind of umbrella topics: primary care, office GYN, prenatal care, contraception, cancer screening, office procedures. And then I'm going to take it and go to a little bit more detailed level. So I'm going to go to the next slide. And once you've got a list of kind of general topics, start to expand the lists with some additional detail. And you see what I did here. If you look on the left side, as you move to the right, I started with my original topic and then I expanded it. So under primary care, well, how about vaccinations? I like vaccinations. How about HPV vaccination? I really like talking about that. So I'm going to look for a patient, and this is obviously an easy one, okay, who got the HPV vaccine or who could have been a candidate for the HPV vaccine, or maybe had gotten it in the past. Okay, and we'll talk about this in a second. When you go to find the patients, it doesn't have to mean that you treated that problem or did that procedure. It might just be that they have it somehow in their history, or we'll talk about it in a second. I'm getting ahead of myself. You'll notice prenatal care. I expanded to advanced maternal age, and then specifically aneuploidy screening, and then specifically cell-free DNA. Well, I'm familiar with this. We do a lot of this. I think I'd like to talk about that. I'd like to find a patient to put on my office list who I did not deliver, but I did some of her prenatal care, and in her prenatal care, we talked about or performed a cell-free fetal DNA test, okay? Cancer screening. In this case, I probably went somewhere you might not go, but I think about cancer screening a lot, and I'm pretty comfortable with some of the primary care stuff. So when I see a smoker, I think, are they a candidate for lung cancer screening? Newsflash, if you were not aware of it, there is a guideline from the U.S. Preventive Services Task Force on screening for lung cancer in certain patients. And so lung cancer screening would be great. And I think because it's a less common topic, one that I'm comfortable with, the examiner might actually ask me something about it if I choose to put this in there. And how would I get a patient with lung cancer screening as part of my office list if I didn't actually do it? Well, I could have a smoker and I could put in there counseling or consideration for lung cancer screening. That would be one way that I could get that topic in there. There's a variety of different ways you can do this, okay? You could put in the problem list, no previous lung cancer screening, okay? Again, there's a lot of ways you can do this. You'll notice in the office procedure, maybe you are making more out of something than it should be. Okay, so that's the first thing. Bolding can be for a pre-op diagnosis. Are they a candidate for lung cancer screening? Newsflash, if you were not aware of it, there is about. You're going to get 50 or 60 of those before you start looking for patients, because you want to give yourself options, okay? And I'm just to show you how easy this is. Here are 20 potential topics that I came up with earlier this week in less than 5 minutes. Cancer screening, cervix, breast, colon. Primary care problems, hypertension, cholesterol, obesity. Contraception, LARC, condoms, contraindications to OCPs. The way I came up with these was I just sat down and thought for about 5 minutes about the different things I've seen in my clinical practice in the last month. And then if it was something I thought I would have some interest in, I put it on here. I didn't list anything that I wouldn't be interested in, but you can see there's so many different options here. And I did list down at the bottom under procedures, male infant circumcision, a procedure that I do perform in my office. So if you do that, it could be something you could include. I'd love to talk about that. I feel pretty comfortable with that. So going to the next slide, once you have your list of topics, 50 to 60 ideally, then go find the patients, okay? Your topic that you want to talk about does not have to be the reason that you saw the patient. And this is important for a couple reasons. First of all, let me just mention that the topic you want to talk about could be in their history. It could be in their family history. It could be in their problem list, but not the reason that you saw them. So for instance, if you want to talk about hypertension, but you don't do a lot of primary care, but you feel comfortable and you're going to prepare for hypertension, then just list a patient in the office list who has hypertension on their problem list, even though you might have seen them for something completely unrelated, like cervical cancer screening, okay? So again, it can be in their history, their family history, it can be in their problem list, but not the reason you were seeing them. It can be a result. It could be a result that you reviewed that was done, a study or a procedure performed by somebody else in another specialty, and you got that result, and you can put that in as a history of. There's a variety of different ways you can use a result in the case list to stimulate a discussion of a particular topic. Or you could even just include concern for in the problem list in a particular patient situation. So for instance, I've put this on the slide here. Maybe you want to talk about metabolic syndrome, which I don't think is a particularly difficult topic, to be honest. It's a group of risk factors that indicate increased risk for cardiovascular disease. And there are 5 criteria, and I think many of you probably know the criteria, and if you don't, you probably should. So you want to talk about metabolic syndrome, but you didn't actually diagnose anybody with it. Well, I think maybe I have a patient with PCOS who, of course, that's a risk factor for metabolic syndrome, and maybe she had one of the criteria for metabolic syndrome. So maybe when I saw her, I thought about, metabolic syndrome as in the back of my mind. Maybe I didn't, but I'm thinking about it now. So on the case list, I put her under the PCOS category, perhaps, which I then list in the problem list, concern for metabolic syndrome. Now, I can review her labs, and she didn't have metabolic syndrome, so I'm not diagnosing her with it. I'm not making up a diagnosis. I am simply stating a concern that is valid in that patient as a way of promoting a discussion of a topic that I want to talk about. Will they always ask you about every single topic that you do in this fashion? Not necessarily, but if you don't list a topic, I guarantee they're not going to ask about it unless it's by chance. And so again, what we're trying to do in this case list preparation, besides having a clean, professional, well-done list, is we're trying to produce a group of topics that we are comfortable with, particularly in the office list, where we get to choose and we can exclude things we don't want as much as possible to come up. And that's why this, in my mind, is my favorite list and the one that most people should be able to optimize, okay? I do want to mention something else. It's the second reason why the topic doesn't have to be the reason you saw them is important, okay? The first reason is that you don't have to be managing that problem to include it, okay? The second reason that this is important is that you have these categories. So ABOG gives you the categories in the office list, and you can only put 2 patients in each one. So say you want to talk about metabolic syndrome, but you've already got 2 patients in the PCOS category. Well, maybe you noticed that the patient had an elevated cholesterol level. So you can put them in, there's a primary care category, and you could put them in there with elevated cholesterol and concern for metabolic syndrome, and bingo, you've got them on there. The great thing here is that you can use different categories to include a patient. Maybe you saw her for cervical cancer screening, but she has something else that you want to talk about. So you get her in the preventative visit or cervical cancer screening. I believe those are 2 separate categories currently on the ABOG list for the office. And you can get these other topics in, even though they may not fit in the category, easily. So you can get extra patients in if the category is already full with other patients, like PCOS, for instance. Okay, so I think I've explained this, but if you have questions, we're always available. So bottom line, the office list, it should be the one you look most forward to. And I want you to really prep that list carefully because it can really, really increase your chances for having a successful office section of your exam. So a few final thoughts for a good office list. And these are, the first one is really important. And this is try to avoid duplications. Duplications are cases that are essentially identical for discussion purposes. And I think I hit on this at the very beginning of this session, but I'm going to make the example one more time so that it's clear. If in the preventative maintenance category, preventative maintenance where you list patients like for their annual exam, if you can put 2 patients in there, if you put 2 patients who are both in their 30s, a 32-year-old and a 36-year-old, I think earlier I said 30 and 31, same deal. the preventative maintenance for a patient who's 32 versus 36 is really the same. So the discussion is not going to be much different for those two patients. So essentially, those two patients only represent one set of topics that the examiner might ask you about. So when you're preparing, you're not going to be able to generate new topics from the second patient. It's a duplicate, basically. Now, I would say you're much better off to list that 32-year-old and then to pick a 65-year-old or pick an 18-year-old. So when we get different cases, then we get more variety. So let me just give a couple other examples. If you have a patient for contraception, because that's a category, if you have two patients who both get levonorgestrel IUDs, it's generally they tend to be pretty similar, and it's a duplication that's not going to help. Makes it easy to fill the list out fast, but doesn't give you a lot of predictable questions that you can prepare for, because if you have 20 duplications on your list of 40, you only have 20 topics. Okay, I'm so oversimplifying, but the point is very important. Another example that might come up, if you have, let's say you have 20 patients you did LEAPs on in your office, and you could list 2 of them in the office procedures category. Unless their diagnoses are very different, and that might be a reason that you might list 2 of the same procedure. But if they're very similar, if really there's not much difference between them, that the 2 LEAPs are just 2 LEAPs. So you might put 1 LEAP and you might put 1 endometrial biopsy or something like that. So again, try to avoid duplications, which when I say duplication, I mean 2 cases that are essentially identical for discussion purposes. And then the last point I'm going to make here as I wrap up is the number of visits. In general, patients that you see more than once are better for the office list, because the idea behind the office list is that the patients would be patients you managed or saw over a period of time. That's not always possible. Like when you take a triage visit to put on the office list or an ER visit on the office list, you probably won't be the person who sees them the next time. And so again, it's okay. There are cases that have only 1 visit. The obvious exception that always only has 1 visit is when you put a patient on for preventative care, unless she had a subsequent problem. But most of the preventative care visits are going to be preventative care cases are going to be 1 visit. For other cases on the office list, it's always nice if you find patients that you saw more than once. It makes it a little bit easier to develop a more detailed discussion, and I think the examiners also like to see that you're managing patients over time. So that's not a huge issue, but just one that I will always point out. So with that said, I'm going to thank you for your time. I hope that the information I've given you will prove useful. I do believe that these are very important points in caseless construction. Again, I want you to remember there will probably be some overlap with some of our other faculty, and there might occasionally be some disagreement on a particular issue. And don't be concerned by that. That's because there's a lot of freedom and